It's a privilege to be presenting this important topic today, and I thank the organizer of NUCD, especially Dr. Alok Kanango, for giving me this opportunity. Today, my topic is time in range, the need of the day. I'll try to show you how we can position time in range, that is shortly called as TIR, in our diabetes management. And this is my financial disclosure. And this is the first topic in my agenda, concept of time in range and its implication in clinical diabetology. You must have seen this slide probably in recent years, especially after the advent of AZ, MS, and CGM. This has been shown to you. So what it tries to tell you is that even if you have a same HbA1c for two different patients, the story behind the glycemic control status is not the same. For example, the first patient has HbA1c of 8, which is a very high glucose variable. You can see the highs and lows, highs with yellow circles and lows with red circles, which is not at all warranted, not at all desired for your patients. At the same time, look at the patient 2. The patient 2 has got the same HbA1c 8.0%, but a very low glucose variability. The glycemic expressions are just staying near the baseline. I mean, the middle line of HbA1c, which is somewhere around 8. Okay, so mean is 8. So all that glitters is not gold. You can see here. The first patient is much more stable diabetic, but the second patient is much more stable in terms of glycemic control, but the first patient has got a lot of problems. And that's where the importance of looking beyond HbA1c and looking at the new concept of time in range in the management of hyperglycemia comes. And this is the topic which I'm going to discuss today. So how do you define time in range? Time in range refers to the time spent in an individual's target glucose range. Usually, it is defined as 70 to 180 milligram per deciliter. That's a broad range. And if you want to narrow it down to a very tight range, that is 70 to 140 milligram per deciliter. And the percentage of time spent below, that is TBR, and the time spent above, that is TAR, range indicates the hypo and hyperglycemia respectively. So we don't want too much time spent in either TBR or a TAR also. TIR may be used as an appropriate endpoint in clinical research, although that has not happened for large clinical trials, but it's probably going to happen in the near future. And it can serve as a measure of glycemic control in patients with diabetes. And there are emerging evidence which is suggesting that time in range is inversely correlated to the risk of developing microvascular as well as macrovascular complications in patients with diabetes mellitus. And I'm going to discuss this in details in my later slides. What is the evolution of this concept? In 2012, a report was published which provided guidelines and recommendations to clinicians and researchers or patients with diabetes mellitus for using, interpreting, and making decisions based on CGM data. CGM was relatively new in those years. And later on, in 2012, the first recommendation by an expert panel on the standardization of the CGM matrix came. In 2017, various publications on CGM matrix and CGM data evaluation also were published. But finally, in 2019, the first international consensus published by Advanced Technologies and Treatment for Diabetes, ATTD, which happened. And later on, ADA incorporated these guidelines into their guidelines. Now, subsequent years, 2019, 2020, even till now, ADA maintains they write one chapter in their standard of practice guidelines for this particular concept, this time in range. So it is gaining popularity. And now let us objectively look at what exactly is time in range. As I have already mentioned, if you put a broad range of 70 to 180, that is your time in range, and the green zone indicates the time, that's where your patients should be all the time throughout the year, but it's not practically possible. So it is recommended for type 1 and type 2 diabetes who are common garden variety of cases without much complication, not special groups. They should maintain at least 70% of their entire days at time within the time in range at 70 to 180. So 16 hours and 48 minutes to be precise. There are some allowances. patients who would have higher, blood glucose, that is more than 180, but less than 250, that is a level 1 hyperglycemia. That can be less than 6 hours. And level 2 hyperglycemia is significant hyperglycemia, more than 250 milligram per deciliter, can only be less than 1 hour or less than 5% of the entire day. If you look at the hypoglycemia, the lower glucose values, so level 1 hypoglycemia is less than 70 milligram per deciliter, and level 2 or severe hypoglycemia is less than 54 milligram per deciliter. So for less than 70, the allowance is less than 4% of the entire day or less than 1 hour. And for level 2 or severe hypoglycemia, it is only less than 15 minutes. So you don't want your patient to be, in that area, because that can have serious health consequences. Now, if you look at the special groups amongst type 1 and type 2 diabetes and pregnancy with type 1 diabetes and gestational diabetes mellitus and type 2 diabetes mellitus pregnancy, so there are some other, allowances. You consider guidelines or cutoffs. For elderly people with high risk of comorbidities, you cannot be that stringent. So more than 50% is the desired level for maintenance within 7 to 180 milligram per deciliters. And the patients can have blood glucose level above 180, but less than 250 or less than 12 hours. So there's some kind of allowance, which we also make for HbA1c. Like we have got less stringent HbA1c goals for these group of people. Similarly, less stringent glycemic control goals for these people. But for these same people, when we said that we should not have very low HbA1c, target patients to have very low HbA1c. Similarly, hypoglycemic range is less than 70, the allowance is very, very low, less than 15 minutes. So because their propensity to develop the hypoglycemia and the subsequent complications are much more in this group. So they should have less amount of time spent in low glucose range. In pregnancy, type 1 diabetes is almost similar to what we have discussed for common garden variety of type 1 and type 2 diabetes mellitus. So less than 4% in hypoglycemic range, and less than 25% in hyperglycemic range, that is more than 140. Mostly you desire a patient to have more than 70% of time spent in the range between 63 to 140. That is somewhat different from the normal common garden variety of type 1 and type 2 diabetes. This is because of pregnancy. We know that pregnant patients who have a lower, cutoff for SMBG or for CGMS values. So that's what is being reflected here. For pregnancy with GTM and type 2 diabetes mellitus, again, you expect your patient to have maintained at least 90% of time within this narrow range of 63 to 140, because you want to be very strict in controlling hyperglycemia in these patients, and allowance for more than 140 milligram and less than 63 milligram, that is called hypoglycemia range, and this is hyperglycemic range is very low. It's less than 5% for each of them. So most of time of the day, 90% time, your pregnant ladies should maintain this glycemic goal 63 to 1. So these are well-defined criteria now, well accepted and endorsed by AD and different other international agencies. So we should understand and remember these cutoffs, because we are increasingly using CGMS and AGMS in our practice. Now, there is an inverse correlationship between HbA1c and time in range. So if you maintain your patients in higher time in range, say suppose 100%, HbA1c is pretty low here, and the patient maintains a very low time in range, HbA1c is expectedly is going to be high. So this inverse relationship is beautifully documented in this table, and you can go through this beautiful paper, and it's a very useful paper where you can get all the information regarding the relationship between time in range and HbA1c. And there is also a very strong relationship between retinopathy, which is a part of a microvascular complication, where you can see that when the patient's time in range is very low, like less than 10, this 58% increase frequency of retinopathy. And if you take a cutoff of less than 70, it is only about 9%. That's why the cutoff of 70 has been incorporated into the guidelines for time in range. So above 70, there is minimal chance of having retinopathy, so that can be considered as negligible. So the problem starts just about 70%. So once you try to maintain a patient's glucose levels at least more than 70% time throughout the day within the target range. Similarly, microalbumin will be also quite strongly correlated with time in range. So if it increases, the chance of microalbumin decreases. There is also another very beautiful paper which shows that each 10% increase in time in range was associated with 6.4% lower risk of abnormal carotid intima media thickness, which is a marker of macrovascular complications. So probably in future we will use time in range as another goal for decreasing macrovascular complications. No doubt. Similarly, you consider if a patient spends more than 70% of time within the range of desired range, there is less chance of major adverse cardiovascular event. The chance is less than 31%, but there is not much difference between 50% and 70% time in range. So probably for macrovascular complication, the cutoff would be in future, time in range of 50%, because they are anyway having a comorbidity, which I have shown in one of the previous slides, that you can be less stringent in patients with various comorbidities, elderly population, and also with known cardiovascular risk, advanced risk factors. The cutoff may not be 70 or 50%. Now, visualizing the benefits of newer analogs to time in range. New analogs are very important tools in our hand or in our armamentarium of treatment of diabetes, which can maintain a good time in range. I'll show you a few slides from a few studies. And this study actually compared the Glargine 100 and Glargine 300. You can see that Glargine 100 cannot maintain the time in range properly because there is a certain peak after the injection. But Glargine U300 maintains it quite well. You can see here, whether you inject it in the morning or in the evening, it maintains throughout the day. But if you inject U100 in the morning, there will be a peak early part of the day. And if you give the Glargine 100 in the evening, then you have a late evening peak. And because of that, the time in range maintenance is rather poor with conventional Glargine injection. So Glargine U300 is better in that. After that, I would like to discuss the comparison between insulin degludec, which has been found to be the best in amongst all the newer analogs, long-acting analogs, so basal analogs, for maintaining a good time in range. And they said there is a significant difference between degludec and both U100 and U300 in maintenance of time in range. That's because of the flat profile of insulin degludec. So it is somewhat lesser in degludec versus U300, and it's rather more prominent in case of degludec versus U100. But nevertheless, by far, this is the best insulin for maintaining time in range, and that's because of its long action profile, and they were very flat without the single peak throughout the 24 hours period. That's quite obvious. And there are various studies to show that although these studies didn't exactly look at time in range, if you extrapolate from the data of hypoglycemia, you can see that almost all the studies have shown that there is a significant reduction in hypoglycemia. That's the most important message from this slide. Insulin degludec, by causing lesser hypoglycemia, it obviously would give you a better chance of maintaining time in range for the patients where it is used. And this very interesting study which showed degludec versus Glargine when added to oral antidiabetic drug, and it is crossover design because it was open label, so decrease the selection bias. It was crossed over, and the same patient would receive both the insulins. And there are very interesting data coming out of this. First, if you look at the maintenance of time in range between the broad target of 70 to 180 milligram, you can see that there is 1.4% more chance of maintaining it with degludec, or 20.6 minutes more compared to U100. Now, if you or narrower range of 70 to 140, again the similar things, even better results came out, because 21.9 minutes on an average, or more spend more in time in range with degludec compared to U100 Glargine, and it was statistically significant. And more patients achieved clinically significant improvement in time in range with degludec. So they compared time in range with OAD. Then they compared the time in range when a degludec or U100 glargine was added, and it was shown that more patient maintaining, it's somewhat like more patient maintaining HbA1c below 7% target. So it can be extrapolated to a better glycemic control without variability. So another important message from that study was that time spent in, hypoglycemia, level 2 hypoglycemia less than 54, level 1 hypoglycemia less than 70. For both, degludec was better. It was significantly better in reducing the risk of hypoglycememia for either one, level 1 hypoglycemia or level 2 hypoglycemia, or even level 1+2 nocturnal hypoglycemia, and that is statistically significant for each of them. So that showed the superiority of degludec versus U100 glargine in reducing nocturnal hypoglycemia, and this came out from CGMS studies with these two molecules. So, in summary, time in range provides a complete visualization of person's glycemic status and aids in better glycemic control. Increasing time in range has shown to reduce micro as well as macrovascular complication in people with diabetes, although we need more robust evidence with larger studies to come out and interpret, but then the early signals are quite favorable to using time in range as a tool for setting our goals for proper glycemic control along with HbA1c, and probably that is going to bear fruit in future. If we talk about various insulins, degludec is far better than insulin U100 glargine in improving time in range. Superiority confirmed by various studies, and it also improves the tight TI, that is 70 to 140 milligram range, and also lowers the nocturnal hypoglycemia both at level 1 less than 54 and level 1 less than 70 and level 2 less than 54 milligram per deciliter. And more patients achieved a clinically significant improvement in time in range with degludec that was shown in the study. Thank you very much for your patient hearing. In the later part of discussion, we can take up questions. Thank you very much.
Thank you.